Hello everyone, this is Prem Kumar Karthikeyan from Biomedical Engineering, Sri Shanmuga College of Engineering and Technology. Today we are going to discuss about ECG interpretation and normal ECG. Before we getting into ECG interpretation, we should know about ECG paper. The ECG paper looks like a graph sheet, but it is a specialized graph sheet. It has the x-axis of time and y-axis of voltage. It has both large and small boxes. The small boxes are the squares of 1 mm square and large boxes are the squares of 5 mm square with the normal gain on the vertical axis corresponds to 1 MV. A 1 MV is nothing but 1 millimeter, that is equal to 0.1 millivoltage. So 1 millivolt is that is equal to 10 millimeter. The amplitude of the wave is measured from the maximum of the wave to the baseline. The amplitude of the large box is 5 mm and the small box is 1 mm. ECG paper. ECG paper are generally speed at a 25 mm per second or 50 mm second, or in some case 10 mm per second may be used for a longer recordings. Generally, we use 25 mm second is a standard one. When a patient receives a tachycardia means we should run it at a 50 mm per second. If the patient has a tachycardia and bradycardia means we should run at 10 mm per second. When 25 mm per second, a small box has a seconds of 0.04 seconds and a large box of 0.2 seconds. When 50 mm per second means one small box is equal to 0.02 seconds and large box is 0.1 seconds. Mostly 50 mm per second speed is used for a tachycardia to regulate the rhythm on the baseline, and 10 mm per second is used for the bradycardia to regulate the rhythm on the baseline. Normal electrocardiogram. Normal electrocardiogram is nothing but we can able to assess the morphology of the waves and the intervals on the ECG curves. Duration of the rhythm. PR interval is duration from 0.12 to 0.22 second. QRS complex less than 0.12 second and QT interval less than or equal to 0.45 second. P wave. P wave is nothing but P wave reflects the atrial depolarization, a distance between onset of P wave to the onset of QRS complex. PR interval assessed for impulse conduction from atria to ventricles. PR segment. It looks like a fat line and slow impulses conduction via the AV node and act as an isoelectric line. QRS complex. QRS complex represents the depolarization of the ventricles. QRS duration is less than 0.12 second and narrow QRS reflects the rapid ventricular depolarization and it indicates the system functions properly. Whereas white QRS complex reflects the slow ventricular depolarization that indicates dysfunction of the heart. J point and ST segment. ST segment acute myocardial ischemia and it causes the deviation of the ST segment. The ST segment deviation can be assessed by help of PR segment. ST segment deviation it has two types, ST elevation and ST depression. J point, the amplitude of the ST depression from the isoelectric line. PR, difficult to discern. TP interval may be used as a reference line. PR interval is used as the reference line to assess the ST segment, depression or elevation. If in case PR segment is difficult to discern means we can able to use TP interval for a reference line. T wave. T wave is nothing but a rapid repolarization of the contractile cells. Generally, T wave is slightly asymmetric and the downslope is steeper than the upslope. In women, more symmetrical T wave. U wave. U waves we can able to see occasionally. It has a positive wave occurring after T wave. Its amplitude is generally one-fourth of the T wave amplitude. The U wave is most frequently seen in leads V2 and V4. Individuals with prominent T waves as well as those with slow heart rates, we can able to display the U waves more often. Rhythm. Cardiac arrhythmias. Rhythm is nothing but the three consecutive heartbeats displaying identical waveforms on the ECG. Sinoatrial node is the heart's pacemaker under the normal circumference and the rhythm is referred to as sinus rhythm. Cardiac arrhythmias can be subdivided into bradyarrhythmias, supraventricular tachycardias, and then ventricular tachycardias. Supraventricular tachycardias is nothing but rapid impulses originating from the atria. Ventricular tachycardia is a rapid impulses originating from the ventricles. Bradycardia. Dysfunctional atomicity in the pacemaker cells are blocking of the impulses somewhere along the conduction system. Cardiac arrhythmia. Abnormal impulse formation can arise, cause the arrhythmias. We can able to has three types: increased or abnormal automaticity, triggered activity. The sinoatrial node may become dysfunctional and fail to depolarize. It will allow for one of the more other pacemakers to take over the heart rhythm. This behavior is the reason why the other pacemakers are referred to as latent pacemaker. Re-entry. All cells ahead of the impulse wave are excitable and offer the equal capacity to transmit the impulse. The impulse encounters cells that are not excitable or areas where the conductivity is heterogeneous. The re-entry might occur. Re-entry means the depolarization wavefront moves around itself in a circle. It is simply an electrical circle loop aberration. Aberration is nothing but it is a ventricular conduction disturbances. If a component of the ventricular conduction system has not fully repolarized by the time the next impulses reach the ventricles, the impulse will be blocked at that point. The length of the refractory period varies with the heart rate. The length is shortened as the heart rate increases, and the length is widened as the heart rate shortens. Example, the premature atrial beat causing aberrant ventricular conduction or right bundle branch block and the resultant QRS complex. So the small r and capital S are morphology. Here, the small r represent the negative deflection and the positive S r shows the positive deflection. Premature ventricular complexes is always known as PVCs. The PVCs is recognized on the ECG an abnormal and white QRS complex occurring earlier than the expected in the cardiac cycle. The impulses discharged from the ectopic focus in the ventricles will spread abnormally. A abnormal depolarization can able to ST to P change as a negative. Bigamy. Every other beat is a PVC. Trigamy. Every third beat is a PVC. Couplets. Two PVCs occurring back to back. Multifocal. PVCs that have a different shape on the ECG, indicating they originate from multiple different locations in the ventricles. Premature atrial complexes. As we same as premature ventricular complexes, it's like a premature atrial complexes. Premature ventricular complexes is occurs at the ventricles as well as premature atrial complexes is occur at the atrias. The premature atrial contraction is produced by impulses discharged from an ectopic focus located anywhere in the atria. The premature atrial contraction induces a delay to the next sinus beat, prolong the R2R interval, increase the ventricular filling. Commonly, the premature atrial impulses arrives before the one of the bundle branches has depolarized, which leads to the bundle branch block. This type of bundle branch block is termed as aberration. Beta blockers. Bis, biso, Bisprosol tablets 5 to 10 mg once daily or calcium channel blockers are the most effective alternatives. Sinus bradycardia. Sinus bradycardia fulfills the criteria for the sinus rhythm, but the heart rate is lower than the 50 beats per minute. P waves with a constant morphology preceding every QRS complex. P wave is positive in lead 2. During sleep, during vasovagal symptom, hypothyroidism, hypothermia, hyperlipidemia. Sinus tachycardia. It is also looks like a sinus rhythm, but its heart rate exceeds 100 beats per minute. It's a result of increased rate of depolarization. That is nothing but increased automaticity in the sinoatrial node is nothing but a SA node. Similar to sinus rhythm, a rhythm is regular with a positive P wave in lead 2. ECG criteria for a sinus tachycardia are the regular rhythm with a ventricular rate greater than 100 beats per minute, P wave with constant morphology preceding every QRS complex. The P wave is positive in lead 2. Thank you.